Hello, my name is David Pedenicchio. I'm an associate professor of sociology at the University of Toronto and affiliated faculty here at Monk. Welcome to the Monk School, Queen's International Institute on Social Policy for this year, 2022. To begin, I'd like to acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory, while the University of Toronto is situated on the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. We are grateful to have the opportunity to live and learn on these lands. For over 25 years, the International Institute has brought together researchers, policymakers, community leaders, and service providers to discuss the most pressing social policy challenges facing Canada and other OECD countries. This year, Queen's University and the Monk School of Global Affairs and Public Policy have joined forces to host an ambitious program focused on whether and how we need to reform or even transform Canadian social policy for a more resilient and successful future. The 2022 Institute launched at a day-long conference at the Monk School on the meta challenges and policy choices facing Canada and other OECD countries, socioeconomic, cultural, generational, and political. Today's session, Falling Through the Cracks, focuses on people with disabilities as well as on mental health. It is seventh in a series of 9 virtual policy seminars drilling down into major areas of social policy that are the most in flux and ripe for rethinking. This session is also available in closed captioning. To use the closed captioning feature, you just have to click on the icon at the bottom right of your screen where it says live transcript. After the presentations, we will have a discussion period. Please send your questions through the Q&A feature, which is also at the bottom of your Zoom screen. I would like to introduce our moderator for this session, Sherry Torjman. Sherry is a social policy researcher and consultant. She was vice president of the Caledon Institute of Social Policy and vice chair of the Disability Advisory Committee, reporting to the Minister of National Revenue, and co-chair of the Technical Advisory Committee on Tax Measures for Persons with Disabilities. Sherry has written extensively on a wide range of subjects, including welfare incomes and reform, disability income and supports, tax reform, caregivers, and community-based poverty reduction. Sherry has received numerous awards for her policy work, including the Senate 150 Medal, Queen Elizabeth II Diamond Jubilee Medal, Champion of Human Services Award from the Ontario Municipal Social Services Association, and Top 25 Canadians Award from the Canadian Association of Retired Persons. It's a great pleasure to turn the session over to you, Sherry.
Thank you. Thanks so much, David, and thank you to the organizers for inviting me to participate in this very important conversation. I'm really honored to be moderating this session with 2 very distinguished panelists today. Just before I introduce them, a few housekeeping items. We are going to the top of the hour, after which time we'll be turning the floor over to a second panel. So we'll have 2 presentations by our colleagues today. And after that point, we'll have a conversation. Please, as David mentioned, put your questions in the Q&A and we'll try to get to as many of them as we can. So without further ado, it's my pleasure today to introduce Suzanne Bruyère. Suzanne is Professor of Disability Studies and Director of the Yang Tan Institute on Employment and Disability at the School of Industrial and Labor Relations at Cornell University. She is Project Director of the National Policy, Research, and Technical Assistance Center on Employment of People with Disabilities, funded by the U.S. Department of Labor, Office of Disability Employment. Suzanne is author and co-author of 4 books and more than 120 peer-reviewed articles and book chapters on workplace disability inclusion. Suzanne, welcome to our session today. Over to you.
Thank you very much, Sherry, and thank you to each of you that are joining us today. I am delighted to be with you and to have an opportunity to share our perspectives on what's happening on this very important topic of people with disabilities who are indeed falling through the cracks in many ways. And I'm hoping that this conversation will help illuminate what each of us can do to contribute to changing to some of the problems that we are going to be discussing for this population. As some of the background of this seminar series talked about, there are a number of institutions that impact the economic support for people with disabilities, and labeled, named, and also what will be discussed today across our two panelists are labor markets, savings and credit markets, family and government supports. I'm going to focus on our area of expertise here in the School of Industrial and Labor Relations on labor markets, and specifically talk about the elements under that in a broad way in the time available that impact individuals with disabilities, economic well-being, the availability of jobs, the ability to equitably access employment to get to those jobs, and once employed, what are the kinds of supports that mean that people with disabilities will likely be able to be retained and thrive in those jobs and advance, hopefully. So my focus today is going to be very much contextual on what's been happening for people with disabilities. So to understand how the COVID-19 pandemic has impacted people with disabilities at the workplace level, and to learn how remote work access and the return to work process has responded to the needs of people with disabilities as we know it to date, and discuss an emerging topic that is having increasing significance to employers, and that is long COVID and how it may impact the workplace for the future, and then summarize with some resulting challenges and opportunities before I turn it over to our next presenter for this panel. So with that backdrop in view, I'd like to start with some commentary on why a focus on COVID-19 and people with disabilities is important and relevant to our conversation today. First of all, people with disabilities are a significant proportion of working age Americans, approximately 11% in the United States. They have historically been disproportionately disadvantaged in employment participation and subsequently economic well-being, as well as experience discrimination in the workplace, both in the application and once they're in the work environment. This has been shown to be exacerbated with economic turndowns. Often people are the first let go and the last to be returned to a economy once it's on the upsurge again. But we do see that companies who are proactively hiring desire information how to affirmatively recruit and accommodate applicants with disabilities, as well as those who are neurodiverse during this COVID return to work time. And we also know from our experience working extensively with employer networks that employers have questions about how to navigate continued remote work and accommodations during the pandemic, as well as risk mitigation, health risk mitigation in the return to work process. So a bit to undergird my comments about economic downturns and deepening inequality for people with inequity for people with disabilities. In normal times, which these are not now, people with disabilities are more likely to experience precarious employment and less likely to report job security. Plus, added the dimensions of public health crisis and disproportionate impact for people with disabilities who may need additional safety and now are more at risk health-wise. We know from past experiences that business cycles amplify negative employment trends for people with disabilities when there are downturns, who, as I mentioned, are often the first to be laid off and the last to be rehired when conditions improve. This has been longstanding economic research that we see verified again and again. As economic downturns deepen inequalities, history tells us that there will be rising numbers of people with disabilities permanently exiting the labor force. So it's time for us to be very vigilant about these potential deepening divides. We also are now looking at how these inequities are exacerbated with looking at those with intersectional characteristics or historically multiply marginalized identities. At the Yang-Tan Institute, we focus on people with disabilities, but in the broader context of the ILR school and as well as society at large, we are painfully aware that people, women and people with racial, ethnic, and gender orientation identities often can be doubly disadvantaged in economic pursuits. So our example here to support that assertion is looking at poverty rates in the US, where we look at gender, men without and men with disabilities. Poverty rates are 8% for men without disabilities, almost 24% for men with disabilities, and even more starkly disadvantaged women with disabilities at almost 29%. We similarly see wider disparities for those with racial, ethnic identities and disability, and some of the highest numbers I will cite here are those with disabilities who are also Black or African American. Almost 36% are in the poverty, under the poverty line, and Native Americans 36%. Hispanic Latinos with disabilities, I'm speaking of 28%, in that case, twice of 14% without disabilities under the poverty line. So we know when you have these multiply marginalized identities, it can exacerbate these significant economic impacts in terms of disparity of employment participation. So with that as a backdrop, these are perilous times for people with disabilities where employment is concerned, and those with other identities could be very much exacerbated. Often are all individuals who may be in lower paying jobs that may have been impacted, service economy impacted by the COVID-19 pandemic. Some of the questions arising around COVID-19 and individuals with disabilities that we're hearing from employers and public policymakers are puzzling over what to do are what strategies can employers use to recruit, hire, and onboard new employees during this pandemic time? What information may an employer request of an employee or a job applicant around their health condition? Are there accommodations that will ensure equal employment opportunities for individuals with disabilities that don't pose a direct threat to the health and safety of the individuals or others in the workplace? And what steps must an employer take to maintain the confidentiality of medical records that they may gain access to in this inquiry during the return to work process? And what are some considerations around reasonable accommodations and COVID-19? So one of the things that we know, those are some questions that we are constantly facing with employers about, is that COVID-19 had a sudden and profound impact on people with disabilities. Workers with disabilities represent only about 3% of the labor force, but they've experienced disproportionate labor market impacts of the COVID-19 pandemic. And the 3% comes from our national census data, looking at who responds and says they're a person with a disability and are currently in the labor force. And specifically looking at data that's more recent, we know from March to June 2020, workers with disabilities lost nearly 1 million jobs, or a 20% decline compared to 14% for workers without disabilities. But compared to prior economic downturns, recovery could be faster, but also must account for the impact of health-related impacted measures. Certainly we see employers trying to reabsorb people in significant proportion back into their workplaces, but we believe that people with disabilities will be disproportionately impacted. But many employers have adopted new ways to maintain operations that could change the nature of work in this country that we're excited about. We'd like to see further promoted and capitalize on in getting people into the workplace, such as flexible hours for parenting or self-care, telework options, and accommodations that often were not allowed prior to the pandemic. And now we have learned how to execute on pretty successfully in many, many workplaces. I also think many of us are acutely aware that mental health issues has become a very high profile area of focus for the country as a whole, our country for sure. And I think it's pervasive globally and for the workplace. So specifically, I'd like to share with you the mental health impact that we know, again, from national survey data around COVID, but particularly this here with a focus on individuals with disabilities. And we see, again, people with disabilities disproportionately impacted, and with females being higher impacted as well. When we look at the mental health measures of anxiety disorder, depressive disorder, and a combination of the two, we see that self-reported anxiety and depression is higher for women in all of those categories than men, and significantly higher than by twice for people with, or more for people with disabilities. So compared to 22% of people without disabilities, 54%, for example, are reporting anxiety disorder, 17% and 50%, again, for people with disabilities, 26% and 62%, rounding up on all of those. So people with disabilities significantly experiencing higher anxiety, depression, in combination of both than their non-disabled peers at this point in time. And this data was from a pulse survey that was taken approximately a year ago. It's a regularly now offered during the pandemic survey. This data was taken from June of 2021. So some employer considerations to affirm continuing benefits in hiring for people with disabilities. Since we see these disparities, we're looking at what might help. We know that now more than ever, there are lessons to learn from workers with disabilities and need for employers to develop diverse and neurodiverse talent pools. Employers are looking for talent, wanting to reabsorb people, and in some cases finding it difficult to find them. Here is our talent pools that have been historically largely untapped, so that we are encouraging employers to think about that. There are many strategies and accommodations like staggered work schedules, telework, remote client interfacing and conferencing that are being embraced by businesses during the pandemic and are already familiar to workers with disabilities, making them an important source of workplace innovation and universal design efforts. Many employers have had to respond, and this has helped everyone in the workplace. And we can now leverage platforms for what we see as the new normal, these virtual environments that presents opportunities to design more inclusive virtual environments and hybrid workplaces. So it's important to listen to the workers' needs to build accessibility and universal design into workspace redesign and reopening strategies to make remote work and flexible schedules a more common feature where possible, and to afford workers flexible long-term leave and benefits, making this a more extended opportunity, prioritizing diversity and inclusion efforts so that we can spur innovation and future-proofing of what we believe will be the new normal. I also want to affirm, and this is data we have been looking at for close to 45 years now from a resource called the Job Accommodation Network, funded by the U.S. Department of Labor, that accommodations for workers with disabilities are not costly. 80% of them cost less than $500. So we're really not talking about a big investment by employers. A few ideas of about accommodations, remote work, and COVID. Offer protection to the individual who might be at greater risk, heightens the likelihood they'll say yes to the job if they say that they need that to be able to eliminate a possible exposure. Talk to the employee about whether the same or a different disability is the basis for a new request, if that should occur, and why additional or altered communications is needed. Conversation is really important. The employer can ask questions or request medical documentation if the employee's disability necessitates an accommodation, if it's not obvious. And if there is some urgency, we see employers foregoing or shortening this exchange of information and granting the request to get people back to the workplace while they might await a receipt of more comprehensive medical information that they may want. And accommodations due to a pre-existing disability that poses a higher risk from COVID-19 is where we see many people focusing. We see a ripple effect on job service provision. I will just mention, I've been focused on what are employers doing, but often employers are gaining access to this pool of talent from service providers who are conduits for qualified candidates with disabilities. And we did see during the pandemic that from qualitative research that there were higher rates of furlough among employment service providers. So their workers were not available to support people. They had work hour reductions. They were voluntarily exiting employment to mitigate risks for themselves in interfacing with the public and providing services and family members among individuals with disabilities. And this has had an important ripple effect on the availability and tailoring of on-the-job supports from these service providers that often help people get into the workplace and stay there. And this was done on a survey of provider organizations, 173 here in New York State, that covered a variety of different types of service positions. So innovations in workplace practices coming out of the pandemic that we are seeing as innovating diversity and inclusion hiring and recruitment practices, inclusive flexible remote work, telework, the role of employee assistance programs to support people through the mental health process and anxiety that they're experiencing, and more progressive performance management, giving people more opportunity to be able to prove themselves and to learn while they're in the process of picking up a job. I do want to mention long COVID that is emerging as a big priority among individuals. I'm sure many are familiar with the fact that it's overwhelming fatigue, some of the symptoms we see, brain fog, making simple tasks difficult, persistent breathlessness, depression, cardiac problems. And we are hearing that it could be as much as a third of COVID-19 patients who still experience some of these symptoms months after they've been infected. And for us, we're looking at possibly 1 in 7 Americans. And the Lancet Journal said that even higher numbers, when these are hospitalized, 60% of almost of hospitalized patients and 26 of non-hospitalized show post-COVID symptoms after infection. It's higher in older people, 40s through 60s. And it's estimated that these COVID disabilities will far outnumber deaths over time. 6 to 8 long haulers for every COVID death. So that's a significant number of people wanting to return to the workplace. And it may account for upward of 15% unfilled jobs is what we're estimating right now as we go looking for workers. So we know that workplaces will need to adapt to bring people back and to accommodate some folks who have some of these symptoms but want to return to work. Here are some ideas that we've learned from our review of the literature, but also our discussion with employers to date. Diagnosis can be difficult. We do see it as a disability under the ADA, so therefore accommodations would be appropriate with using an interactive conversation with the individual. Workplace flexibility, telework, flexible scheduling can be helpful. Access to paid leave, and for us, it's under a Family Medical Leave Act that we have, and we do see significant continuing enhancements to mental health services. About a third of people contracting COVID report heightened anxiety and depression, and that's not necessarily long COVID. That is more generalized to people who had the infection. Accommodations, they exist. Important to prepare supervisors for these conversations, how to discuss some of the symptomology and how it affects performance and what might be possible accommodations for fatigue, for example, like minimizing physical effort, using different kinds of tools to do that. For brain fog, maybe different lighting, electronic organizers, modified break schedules, written instructions. And for us, it is built into our Americans with Disabilities Act. You have to talk to the individual and ask them what they're experiencing and what might help. So our challenges and opportunities for the coming decade: continuing disparities in employment participation for people with disabilities, exacerbated for those with historically multiply marginalized identities. Long COVID, as I mentioned, heightened mental health issues, all our challenges. Opportunities: there are many job openings and employers are looking for talent. Hopefully people with disabilities will be the talent they're considering, among others. We have more flexibility in workplace policies and practices, which definitely could help people with disabilities, and an increasing openness by employers to new types of workers and how to skill them up and support them. And with that, I will leave you with some resources on the topics that I've hit upon. and I'll turn this over to my colleague. Thank you.
Thank you so much, Suzanne, for that excellent presentation. We have so much to learn from you. I personally have many, many questions, and I hope that participants who are on the line will enter their questions as well in the Q&A box at the bottom. And before we go to questions and conversation, it's my honor and pleasure to introduce our colleague, Michael Prince. Michael has contributed enormously to social policy in Canada. Michael joined the University of Victoria in 1987 as Landau Professor of Social Policy in the Faculty of Human and Social Development. He's an adjunct faculty member in the Department of Political Science at UVic. Since 2018, Michael has been the board chair of Community Living BC, and he's an active volunteer with a number of national disability-related organizations, including the Council of Canadians with Disabilities and Inclusion Canada. Michael serves on the Ministerial Disability Advisory Group to the Honorable Carla Qualtrough, Minister of Employment, Workforce Development, and Disability Inclusion. So Michael, over to you for your presentation. Thanks.
Thank you, Sherry, very much. And good afternoon, everyone. I'm calling from Victoria, from the traditional territories of the Lekwungen speaking peoples. And it's a delight to be here today and be with Suzanne and Sherry and all of you. The title I gave for my talk is Far Worse Than Falling Through the Cracks. So I wanted it to consider the notion of falling through the cracks and conceptualize that. And so I started with some old ideas from classic writers like Irving Goffman and Kimberly Crenshaw about intersectionality and how people's personal identities often reside in the cracks of life and in our social world. And a quote from Michel Foucault saying, "What I seek is a permanent opening of possibilities," which to me speaks to some of the grander themes and aspirations of the workshop and then the entire institute this year is not only diagnosing or documenting some of the current challenges, but looking ahead to what possible innovations and reforms may be imagined and considered. And I think Suzanne put a wonderful backdrop to us in looking at the experience in the United States. I start with some working assumptions. We've been asked to think about what the coming decade may present to Canadians with disabilities and to policymakers and to individuals and families across the country. And we know that in the coming decade and even beyond that, Canada will have an aging population, an older population, and then thus proportionately a more disabled population. We know that there's a close correlation between aging and the onset of impairments or disabilities. So as Canada ages as a country, it will also become a more disabled population in terms of functional limitations or impairments. Now, the question behind that is whether, as it becomes a more disabled population, whether Canada becomes more or less a disabling society or a more inclusive and accessible society, and therefore a more enabling society. And that's, I think, really kind of the big macro political question. And what animates a lot of activists and social movements in the disability community is about these questions of barriers and obstacles and inequities.
Michael, excuse me, I don't think your slides are up.
Oh, they're not? Oh.
Can you share your slides? Sorry.
I'm sorry. Thank you, Sherry.
Okay, no problem.
Thank you. My apologies, folks. Okay, can we see the slides now? Yeah, and we can walk. Okay. So here, again, just some of my working assumptions about falling through the cracks that that does capture, I think, some of the experience, obviously the historical experience, again, as Suzanne nicely documented some of the experience in the United States. I would say that a lot of that is very common and similar in Canada. For example, one of her statistics was about Native Americans and the disability rate as of around 35%. What data we do have in Canada, and we don't have a lot of great data on disability rates and poverty among Indigenous peoples with disabilities, but the numbers we do have are very similar, that 1 in 3 or so have similar kind. And to me, some of those deep disadvantages raises the question as to what extent the metaphor of falling through the cracks really is an apt or accurate, appropriate kind of description of what is going on and facing people. So kind of one of my themes today is that we need going forward, a fuller vocabulary of concepts and images or metaphors to think of and talk about issues facing and challenging Canadians with disabilities, and also how we then, using that language, take action on addressing inequalities and systemic hardships. This next slide just is a reminder of, like any other group or category of people in society, people with disabilities display a huge array of diversities, whether that's embodied diversities in terms of the types of physical limitations or health conditions they have, the experience of when disability occurs in someone's life, whether it's from birth or later in their life, the degree of severity of that impairment or condition, the degree of permanence, or whether it's a more episodic or cyclical disability, whether it's visible or less visible to people around you. And also, again, to just echo Suzanne's point about intersectionality, disability as a marker of social identity does interact, of course, with a person's age, their ethnicity or race, their gender, where they live in terms of locality, the kind of education they may have, and other socioeconomic indicators such as income or wealth, and also their household living arrangements. And those in turn all intersect with different kinds of prejudices and discriminations that happen in our societies, whether that's ageism, racism, sexism, or other forms of stigma and prejudice. Disabilities also vary in terms of the public awareness and understanding of particular conditions, their kind of familiarity to the public, and the comfort level that the public generally may have around certain conditions. And with that then has implications for acceptance and or negative stigma around particular disabilities. And over time, governments have responded to different kinds of disabilities in different ways. So the state has responded in a variety of ways, privileging, one might say, certain kinds of physical disabilities or other impairments historically, and in more recent times, struggles around mental health, which is the topic of the next panel. So my theme is on the use and limits of metaphors. And I would suggest that the term falling through the cracks is useful. It does promote a lens on looking at what the pandemic's consequences have been for people with disabilities in Canada, and what the potential lessons may be that we draw from that. But I'd also at the same time argue that the idea of falling through the cracks captures just part of the lived experience of Canadians with disabilities. It suggests that there are gaps in what is otherwise a fairly adequate and extensive network of systems and programs and policies across the country, and that the cracks really appear amongst a much more solid surface of supports. It depicts only certain characteristics of the policy landscape, I think, and therefore it risks ignoring the needs for more transformational reforms in some of the practices we have. In other words, there is a disconnect between the conceptual or the linguistic and the empirical and the lived experience of people with disabilities. And so we need to really think about how to go beyond talking about falling through the cracks, which is a very conventional and very common way of talking about social policy and people who may be underserved, and think about some other images in terms which I'll get to in a few minutes. Again, as Suzanne pointed out, we were given a terms of reference, so to speak, for this panel that to consider 4 main types of institutions that contribute to or impact the economic support for people with disabilities. And those, as Susan noted, were labor markets in the workplace, which she focused on, savings and credit markets, families, friends, and neighbors, or informal support networks, and government support. And of course, others could be added, such as the role of faith-based institutions in a society, the role of nonprofits in the voluntary sector, and of course, Indigenous organizations and institutions, which also play an increasingly important role in this area. I'll try to touch on all these in the brief time I've got, but let me turn to the topic of what the lessons of COVID may be for people with disabilities and for Canadians more generally. And again, just to be selective here, one area where I think we saw profound impacts were in the health and social care sectors. And one of those has to do with what I call the tragic paradox of long-term care. It's a paradox in that, on the one hand, people with disabilities are often socially identified as people who are sick, elderly, and frail. So a very common notion or image of people with disabilities in this country are, in fact, people who did live in or do live in long-term care facilities, nursing homes, and other kind of residential facilities. Yet at the same time, during COVID, it was this very population in congregate care settings that suffered extreme vulnerabilities and what I call wretched outcomes. And just to remind us of images of the Canadian military being dispatched to long-term care facilities in different parts of the country, the disproportionately high rates of death, preventable deaths in congregate care settings that happen in Canada during COVID. And some of these, I think, point to some institutional failures. The lack of trained staff and trained and prepared management for arguably, of course, a highly unique pandemic, but it exposed some other longstanding problems that existed well before the pandemic came. Failures around just the poor physical design of our facility buildings, overcrowded, poor ventilation, a longstanding concern about weak regulatory oversight by provincial governments on the operations of long-term care facilities across the country. And another lesson, I think, was from families was the absence of a right to be involved, the right for scrutiny, and thus the holding accountable staff and management over the day-to-day operations and the fate of the lives of their loved ones in these institutions. Turning to another area of lessons of COVID for people with disabilities concerns income security. And again, just as a quick refresher here, through the year 2020 and 2021, of course, we saw a massive undertaking of expenditures by the government of Canada on financial supports as the lockdown happened and millions of Canadians were thrown out of work. We had innovations such as the Canada Emergency Response Benefit, or CERB, that went to millions of workers. That included many workers with disabilities. There was also financial aid for post-secondary students with permanent disabilities. There was some special support also provided to Canadians over the age of 65, to seniors. And again, a large proportion of seniors, of course, are disabled, although they were not framed as disability initiatives. Other groups who had not received benefits in those ways waited and waited for an eventual one-time $600 payment. And it was delivered through those who were eligible for the federal disability tax credit, which serves about 1.2 million Canadians. It sent a signal to a lot of Canadians with disabilities that they were an afterthought and that they'd been forgotten by governments. Another impact of the income security experience over the last few years is that some disabled persons who were on social assistance, provincial or territorial welfare programs, who also qualified for CERB and received it, saw those CERB benefits clawed back either by about 50% or in some jurisdictions, 100%, so a complete offset. There's only one province in the entire country, that was British Columbia, where the benefit was, the province allowed the benefit to flow through directly to persons with disabilities on social assistance who are also eligible for the CERB benefit. And this shows the complications of program interactions and federal-provincial relations. It also pointed to the need for a new federal disability income supplement program, which is currently before the House of Commons as a bill, and is intended to fill what was seen as a large gaping hole in the social safety net, to use another metaphor. So the institutional failures that I think we can take away from what the income security system was, first of all, was that it was a reminder of the labor market employment barriers that many people with disabilities continue to face in Canada. Excuse me. A lack of cooperative federalism in the way programs interact. The lack of awareness by Canadians about some of the programs that they may qualify for. And at the federal level in particular, the absence of integrated administrative data sets between and among federal programs and services and benefits and programs. So again, this was part of the lessons for the need for a new federal benefit. We were asked too to look at the coming decade and what sort of challenges and possibilities there may be. When I look ahead, I see multiple forms of politics and different publics and different agendas. One that's clearly been apparent in Canada in the last 5 or 7 years or so has been a return to a more redistributive politics in Canada, a more active government of Canada in introducing redistributive programs and resources to different disadvantaged groups, plus an agenda of poverty reduction. We now have legislation in place in Canada at the national level with an official poverty line. And so that will be an agenda with certain publics and stakeholders associated with it. Reconciliation with Indigenous peoples, which is a work in progress for the First Nations, Métis, and Inuit in this country. Here too, there'll be an interesting question is how that intersects with more mainstream disability policy discourse and reforms. Diversity and equity, often we think here in terms of both traditionally women's place and status within the labor force and other institutions, and more recently racialized communities in Canada and opportunities for more equitable employment opportunities, among others. And finally, accessibility and inclusion might be the key words for the disability agenda going forward. And again, we have recently passed Accessible Canada Act in 2019, and there's now rolling out other initiatives in advancing inclusion for Canadians with disabilities. I project here that we might see in part a dynamic of what I would call progressive incrementalism in trying to shift the cultural beliefs, public policy, and service practices that affect Canadians with disabilities. So keeping an eye on time, I just want to, the next several slides, I look at the 4 institutional domains that we were asked to consider to look at how we talk about them and how we do need, I think, different language to consider them. Now, let me just go to one of them. I do one on labor markets. There's one here on savings and credit markets. But I want to talk about families. And here, when we talk about families falling through the cracks, that often is usually focused on a particular, we see these in news stories and media coverage, a particular individual or family that's been on a wait list for some social service or healthcare or housing or other personal supports. Or they are inadvertently deemed ineligible, or they experience a runaround between different program silos. But I think what we need to talk more about beyond falling through the cracks, that some families have dropped or plummeted into very deep canyons or fissures where they have unmet needs for years after years. There's tremendous burnout and stresses on informal caregivers, and there's threats of abandonment, and there's marriage breakups and family disorganization as a result of that. I think even more profound or troubling is families that disappear into the abyss. And here we have occasionally, not very often, but we have occasionally cases of murder-suicides where a parent murders their son or daughter and then commits suicide because of the isolation and the complete desperation and collapse of supports around them. These don't happen very often, but they happen too frequently in Canada still in the area of disability supports and services. There are maybe other indicators of what might be called disappearing into the abyss. In the area of government supports, it's chronic homelessness. Okay, Sherry, I will wrap up pretty soon. So my conclusion is falling through the cracks is a conventional metaphor that offers one way of understanding experiences and highlights some programs, but it's not a metaphor that we all live by. And it doesn't apply equally to everyone in our communities. We have a need for other kinds of language. We need terms for other narratives to better see the experiences that are really besieging a lot of Canadians with disabilities. We need new language that will stir political imaginations and conversations as we go forward. And ideally, that language will help us not only to how we think and talk about things, but how we then take actions across all those institutions. And again, like Suzanne, I've provided some resources and evidence and sources that help guided my conversation. I'll turn it back to you, Sherry, and thank you.
Thanks so much for that excellent presentation, and the slides will be made available to participants. Michael, you covered a huge territory and you have so much knowledge. So thank you very much for your presentation today. Yeah. I have, there's just a few questions. I had quick one to ask of each of you, if that's okay. You know, Michael, I agree with you that we need a new narrative. It's absolutely essential. I think we also need a more positive narrative. We've been very negative. And at the end of the day, on October 31st at the Monk Conference, Carolyn Toohey talked about positive narratives and negative narratives, and we tend to always fall into the negative narratives. And maybe we can provide some more positive aspects to the narrative. But in addition to that, I'm wondering whether we have allowed the policy conversation to fall into the corners on this sort of side of the envelope. Why aren't we having disability conversations with employers directly, like Suzanne has discussed, with communication and trade and bankers? And it's not just a few people who are affected by disability. Disabilities are us. And, and unless and until we actually get disability conversations into the mainstream, I think we're always going to be falling between the cracks. So I don't know if you have about that. Did you want to comment, or maybe I?
Do you want me or Suzanne, or either one?
Either one of you. My question to Suzanne just had to do with, Suzanne, given everything that you've been able to achieve and your, exciting innovations, do you think that we focus too much of our policy conversation on governments alone? Not that governments are unimportant by any means, clearly. You've been able to achieve so much by working directly with employers, and I'm wondering whether that's an important lesson for us here back home. So either one of you, please, and then we'll go to some questions briefly from the floor.
That's a great question, Sherry, and an appropriate observation. We have a center that a subset of our center that is over 30 years old that is focused on implementation of the Americans with Disabilities Act. So it is not by any means that we don't respect and appreciate and support what regulatory frameworks have afforded us in terms of protections for individuals. But I think we also recognize that regulation can't impose changes in workplace culture, and really building inclusive work environments is what's going to make a difference. We know from research that if supervisors are told that they have to include people with disabilities and accommodate because the company doesn't want to get sued, which happens in the United States, or that they have to abide by the regulations, rather than the employer really wants to build, truly wants to build an inclusive workplace where everyone can thrive, it makes a huge difference in terms of how people who are the outliers in that community are treated. So that messaging is really important. And we feel we have a responsibility to also work with employers and inform them of how potent their policies and practices are to making a difference in true inclusion for people with disabilities.
Excellent, thank you. I don't know if you have any comments before we turn to the floor.
Sure, Sherry, thank you. Yeah, and thinking about approaching this paper, I kind of went down this, not rabbit hole, speaking of another metaphor, but about just the language we use. I mean, I could have done a presentation with a lot of statistics and talked about all the depressing barriers and for those of us who've been in this field a long time, that's often the common experience when we go to workshops and conferences, is we just hear about all the barriers and all the problems. And I think you're right. When you look at what the UN Convention talks about, one of the articles does emphasize the importance of raising awareness, and shifts in professionals' attitudes and knowledge of disability and policymakers. When you look at the certainly the ADA in the United States, but also in Canada, our ACA, the Accessible Canada Act, part of that piece of work is cultural shift. And the Minister for Disability Inclusion in Canada, the Honorable Carla Qualtrough, emphasizes that a lot, that, one of the biggest barriers is attitude. So it's attitudinal. And we see that in the mental health area as well, big time. And human rights commissions, we're seeing happily, I'm seeing a revived role of the Canadian Human Rights Commission addressing disability. You know, it was one of those intersectionalities that kind of dropped off the main agenda, and kudos to them to bring it. And again, shifting public awareness, whether it's employers, and as Suzanne said, their understandable concerns or worries about liability and cost, et cetera, et cetera. And we're prisoners of our own history, and that we have often taken, there's a history of the charities and the histories of very fragmented approaches, and thinking we can program everything through a public program, which often has disempowered and marginalized. So you're right. I think we can't forget the role of governments, but we have to look at these other institutional interactions in a much more creative way. And I really like what you said, with a more positive narrative, and not just euphemisms, just not to make people feel better, but more that really truly connect empirically and experientially to people's experiences and their hopes and aspirations.
Right. And I think these are some very important policy lessons for the policy workers of the future who are joining us today on the call and on the line, and to have these other broader ideas. I think we have time for just one question. Unfortunately, we're reaching the top of the hour, but perhaps I could direct this to you very briefly, Suzanne. It's a question about somebody who by somebody who asked, how do employees with health conditions that may not technically be considered medically a disability or temporary disability, how can they be competitive in the workplace? Because oftentimes they're told by employers, just work harder. And so how can we ensure that the accommodations apply to those people as well? And in Canada, it certainly applies to your long COVID conversation too.
Yes, well, I think it's an excellent question. I think people with chronic health conditions that were non-obvious have historically hid those conditions and not asked for accommodations out of fear of being treated differently or viewed differently, and therefore compromised in terms of advancements, etc. And rightly so, because we certainly have seen that. I think with the changes that the pandemic have imposed on workplaces, I think that people are more empowered than perhaps historically they perceive themselves to be able to ask for accommodations. We know from our research, 95% of accommodations that are asked for from national survey data, come from people other than those with disabilities. They come from the general workforce that need all kinds of tweaks to how they're working to be able to be effective. So I think acknowledging that employers just need to think more broadly, and people need to come forward and say, well, it will take for them to stay able to perform and be functional in the work environment. I think having ERGs, employee resource groups, helps to give them support in the voice that they need to now be bringing forward.
Excellent. Thank you so much. On that note, I'm sorry we couldn't get to all the questions, but I wanted to thank both presenters, Michael and Suzanne, for your excellent presentations. Thank you to everybody on the line. And right now I'd like to turn the floor over to David to wrap up this session and then turn it over to the next panel. Thanks so much.
Thank you.
I mean, a huge thank you to our moderator and our panelists, Sherry, Suzanne, and Michael, for this really engaging, really salient discussion as one of the most topical, I think, and important social issues facing Canada and other countries as well right now. So the presentations and videos from today's session will be posted to the conference website. The next policy seminar in the series will be on Friday, November 18th from 12 to 1:30. And the topic for Friday's session is the public and political landscape, prospects for the future of social policy. And the speakers for this session will be Bruce Anderson, who's the CEO of Abacus Data, and Carol Doherty, Director of Political Research, Pew Research Center. And you can register online for this and other sessions in the series. Just go to the conference site on the Munk School of Global Affairs and Public Policy's website. So before closing, I want to thank Employment and Social Development Canada and Immigration, Refugees and Citizenship Canada for their generous support, which allowed this to bring leading international and Canadian experts together in this public forum. And I'm very happy now to turn it over to Carolyn Tooney. Our next focus in this session is mental health. Thank you again.
Thanks, David. Bye-bye.
Hello, everyone. My name is Carolyn Toohey, and for those who are joining us at this point, I'm very pleased to welcome you to this 8th in our series of virtual panels, 7 sessions, 8 panels in the Monk School Queen's International Institute on Social Policy for 2022. As David did at the beginning of our first session, I would like also to acknowledge that the University of Toronto is situated on the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River, while Queen's University is situated on the traditional Anishinaabe and Haudenosaunee territory. Today, these meeting places are still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to live and learn on this land. And as we enter into this discussion today, may I ask you also to reflect on the land on which you are currently situated. Again, for those joining us at this point, for over 25 years, the International Institute on Social Policy has brought together researchers, policymakers, community leaders, and service providers to discuss the most pressing social policy challenges facing Canada and other OECD nations. And this year, Queen's University and the Monk School of Global Affairs and Public Policy have joined forces to host an ambitious program focused on whether and how we need to reform or even transform Canadian social policy for a more resilient and successful future. The 2020 Institute launched on October 31st at a day-long conference at the Monk School on the overall challenges and policy choices facing Canada and other OECD countries, socioeconomic, cultural, generational, political. And today's panel concludes the series of seminars, virtual seminars, focusing on major areas of social policy that are in need of rethinking and reform before we turn to an overview of the public and policy landscape for policy reform in our final panel on Friday. Positioning mental health as the culmination of the substantive areas to be considered as appropriate. Mental health issues pervade all of the other areas of social policy that we've considered so far, from our opening panel on the labor market through to the panel on disability that immediately preceded this one. These earlier seminars are available for viewing on the Monk School of Global Affairs and Public Policy YouTube channel, which is linked through our website. And today's panels will be posted after this session is completed. So given the relevance of mental health to all other areas of social policy, I'm especially pleased that we have two of the most knowledgeable analysts of these linkages in Canada and international, who bring not only that knowledge, but also their active engagement in the policy process to the table with us today. First, I would like to introduce our moderator for this session, who himself is deeply engaged in addressing mental health issues, who will then take over to introduce our two distinguished speakers and manage the discussion. Tatum Wilson is the CEO of Children's Mental Health Ontario. He is a true sector-spanning professional with over 20 years of experience in multiple health and social policy environments, including government, academic health science centers, and advocacy organizations. His accomplishments include overseeing the development of Ontario's first comprehensive mental health and addiction strategy, and managing the development and implementation of Ontario's first poverty reduction strategy. Tatum has an honors Bachelor of Arts in Political Science from McMaster University and a Master of Health Science and Health Administration from the University of Toronto. He is a passionate promoter of equity and social justice issues and a leader in community engagement, communications, and advocacy, and we're grateful to have him as our moderator today. Tatum, thanks for leading the seminar. Over to you.
Thanks so much, Carolyn, and it's great to be here. I have to laugh, maybe pinch myself a little bit, that in 2008, so 14 years ago, I staffed Minister Deb Matthews, who was the Minister of Children and Youth Services at that time, who came and spoke at this very conference when it was in person in Kingston. So it's nice to come full circle and be able to participate again today. So I will just get right to introducing our panelists. But I do just want to acknowledge, you'll see three men on this panel, which raised my own question about our representation on this discussion. And again, it's, I myself took a look at the overall panelists for the conference, and there's a lot of diversity throughout it, but I do just want to acknowledge that this is, it's three men, maybe, and something that we probably are trying not to do all the time as much anymore. So, but without further ado, I'll get to introducing Howard Goldman. Howard is a professor of psychiatry and the director of the Behavioral Health Systems Improvement Collaborative at the University of Maryland School of Medicine. He joined the faculty in 1985. And Dr. Goldman is a mental health services and policy researcher with a special interest in the organization and financing of services. He chaired the MacArthur Foundation Network on Mental Health Policy and served as the senior scientific editor of the Surgeon General's report on mental health, for which he received the Surgeon General's medallion. There is a bit more here, but I think you probably want to hear more from Howard than from me. So I'll turn it over to Howard now, and then following Howard's remarks, I'll introduce Quam. So Howard, please go ahead.
Thanks, Tatum. Thanks for cutting it short. And thank you to Carolyn for introducing the session and for inviting me. I'm very pleased to be here. This is an area of great importance to me and to our whole field, seeing the intersection of mental health and social policy. First, I want to establish my connection to Canada. Even though I'm a US citizen, I grew up on the outskirts of Windsor, Ontario, just north of the Canadian border in Detroit, Michigan. I peered on a daily basis at Canada across the river, and I've traveled far and wide across Canada, some of it by canoe in Algonquin and Quetico Superior, and a lot of it on foot in other provincial parks, Waterton, Banff, Lake Louise, and the west coast and south coast of Vancouver Island. And I have great admiration for Canada, both for its physical beauty, but also for the communitarian spirit of its populations. And I feel very close to Canada, both from these experiences and more recently from an invitation that I received for a professional connection. That invitation came a little more than a decade ago from the Graham Beck Foundation and from the Canadian Institutes for Health Research. They were considering the strategy for patient-oriented research and wanted to develop a demonstration program in adolescent mental health, particularly focused on early intervention. This had particular interest for me because from the beginning, it was a combination of trying to make clinical change with early intervention, but recognizing the importance of social policy and community organizations in promoting mental health amongst a young population. And it was this connection to social policy and social services that attracted me to the initiative right from the get-go. The project came to be known as Access Open Minds, or Ouvert, Esprit Ouvert. And it was a pan-Canadian demonstration program in 6 provinces and 1 territory. It was funded in 2014 and had just about wrapped up. The initial principal investigator was Ashok Malla at McGill. He's now an emeritus professor. And I had occasion to read some of the first reports that came from the demonstration and comment on them in an commentary called 49 Degrees North, where I made comparisons between our efforts in early intervention with youth and young adults and the Canadian approach. But what characterized the effort in both settings is the illustration of the importance of social policy in mental health service delivery and mental health policy. And I think the way we set this up, I'm counting on Professor McKenzie to deal with the importance of social policy, of mental health and social policy, kind of the figure-ground relationship. Whereas my focus is going to be on the evolution of mental health practice, service delivery, and how social policy has played a critical role in the development of those policies. So what I plan to do is talk a little bit about a series of cycles of reform starting in the late 18th and early 19th century, and show how there has been a connection between these policies and broader social welfare policies. This has been an important area for me, even since my own training, because my advanced training after I finished my training in psychiatry was in social policy. And it really set the frame for the rest of my career. What I'd like to do is outline very briefly 3 cycles of reform in mental health service delivery that focused on early intervention, with the idea that early intervention would prevent the development of chronicity. And then how a 4th cycle of reform, an era that we're in right now of community support, has taken a much broader perspective and is focusing on people who are already disabled. And that's an important connection to the prior hour's presentation. So if I start, the 3 cycles of reform that focused on early intervention were characterized by a set of interventions called moral treatment that were associated with asylum care. The second was the mental hygiene movement, which was associated with academic medical centers at the turn of the 20th century and featured psychopathic hospitals, smaller academic inpatient units, and some outpatient care. And then in the mid-20th century, the community mental health movement and its affiliation with community mental health centers. All of them really were predicated on the public health concept that early intervention in a mental disorder would prevent the evolution of disabling characteristics and dependency in the population. Now, this contrasts pretty dramatically from where mental health services were delivered prior to the moral treatment era in the early 19th century, late 18th century. We saw mostly so-called undifferentiated social welfare institutions like almshouses and poorhouses, and even jails that housed people with mental disorders. But this first reform effort specialized the care, and it was largely a clinical effort, because the idea was that if you intervened early, people would not become disabled, and if they were no longer headed for disability, there was really little need to concern oneself about broader social welfare issues. The person would return to an ordered mind, and they would have recovered and be set straight. So it was largely a public health and a clinical model. It just turned out that the interventions of moral treatment weren't particularly effective at accomplishing this goal of preventing disability. And so the attitudes became quite pessimistic, and the institutions, the asylums, grew larger. They weren't particularly well funded, and a period of pessimism set in throughout the remainder of the 19th century until we got to the progressive era and the rise of academic medicine and medical school service centers, and the rise of neuropathology and neuroanatomy. And the thought was, again, this public health idea had a resurgence. The progressive era gave us a variety of hygienic approaches, some of them not that in retrospect are quite nefarious, like the eugenics movement was also part of this effort. But the progressive era gave us mental hygiene. It gave rise to smaller psychopathic hospitals affiliated with medical schools. But once again, the treatment technology just was not really up to its original intent. And by the beginning of the First World War, the ideas had not been forgotten, but they really did not have the sway that was needed, nor did they have the technological skill to realize their objectives in preventing chronicity. And then the two world wars and the Depression taught us quite a lot about the burden of mental disorders. Conscripts were turned away in both world wars because of psychiatric problems and intellectual limitations. And then the war itself, combat produced shell shock, as it was called, traumatic disorder in World War I, and in World War II, combat fatigue. And when the soldiers, and particularly the physicians, returned from World War II, they felt they had learned something new about intervention. It was again predicated on this public health sense of early intervention, because they realized that when they treated soldiers who were suffering from traumatic stress in combat, if they were evacuated to the rear and not to a hospital far away, but close to the front lines, and were allowed hot food, to get cleaned up, to rest, to have somebody to talk to, they were able to return to their colleagues in the front lines. And this lesson led once again to a resurgence of the idea that early intervention, this time in community settings, would prevent chronicity. What happened during this community mental health period, which had its beginnings right after World War II, but in the United States came into sort of an expansion period in the 60s during the Kennedy and Johnson administrations. We learned that we could treat ever increasing numbers of people with mixed syndromes of anxiety and depression, as well as the people with psychotic illnesses that had been the main focus of interventions in previous years. What happened, however, is that we also decided that we could do without as much inpatient hospitalization. There were a series of exposés that showed how these institutions were overlarge, underfunded, and not very therapeutic in their execution. And what happened by the mid to late 1970s, social reformers in the mental health field began to argue that we needed to focus our attention on people who were already disabled and not focus entirely on or exclusively on people in the early stages of mental illness, because we were neglecting those who were most in need. And what was different in particular about this period, which came to be known as the community support era, recovery became redefined as not returning to some sort of status quo ante, but to an increased level of social participation and social integration. And what it necessitated was an involvement in broader communities and a greater involvement in the social welfare system. It was a move away from the three previous cycles of reform, which were largely medical and public health in orientation, highly optimistic, but under treated. There was, the treatment was just not adequate to prevent chronicity, and recognizing that there were things that could be done to provide support, but suddenly mental health policy became a broad social policy area. People in the field had to become experts in disability policy, the topics that we focused on in the prior hour-long conversation, disability benefits policy, labor policy, vocational rehabilitation policy. If we intervened with young people, we were talking about knowing about educational policy, housing policy. People who were suffering from psychotic illnesses were often ending up being connected to the criminal justice system, the transportation system. Suddenly, to become a mental health policy person and to be a planner for mental health services meant becoming schooled in broad social welfare activities. And it was a very important transformation, but it caused us to become focused on many fronts to improving each of these areas of potential social support for people who are in the throes of a longstanding mental disorder, some of whom were very disabled, others who are able to recover, but still needed ongoing support. So progress was made during this current community support era, but it gave rise to the development of a wide array of interventions, many of them team-based interventions, but they include evidence-based practices such as assertive community treatment, family psychoeducation, individual placement and support, supported employment that's been deployed to help people who have psychiatric functional limitations to be able to work in competitive employment, very effective. And as our experience with these treatments and service delivery models progressed, we began to make the observation that individuals who were treated earlier in the course of a psychotic illness in particular had better outcomes. So we call that period the duration of untreated psychosis, and shorter durations of untreated psychosis were associated with better outcomes when people received these treatments and services that had been designed for people who were already disabled, but turn out to have been quite advantageous for the delivery of services to people in a first episode of psychosis. Now, the services in early intervention developed outside of the United States for almost a decade before they became more widespread in the US. And it's very connected to broader health policy. The examples in Europe, in Denmark, in the UK, in Australia in particular, and then in Canada illustrated how if you had adequate health insurance and a better social welfare, social safety net, you could improve outcomes faster than we were able to do in the US, where we were still in the middle of the community support era, focused almost exclusively on people who were already disabled. And it was tied to how we financed our system. Our system was entirely dependent on public insurance for people who were already found to be disabled. And so young people who were not yet disabled often lacked health insurance. And once they became symptomatic, they would be considered to have a pre-existing condition and would become ineligible for health insurance. So we had a structural impediment in the United States that precluded early intervention services for being part of our public mental health system. This was helped along, ameliorated by the Affordable Care Act, so-called Obamacare, because one of the most important and underappreciated aspects of this health insurance reform was that one could get on Medicaid or public insurance on the basis of low income and not on the basis of low income and being found disabled in our Social Security disability program. Once this happened, it opened up coverage for young people. And another provision of the Affordable Care Act was that individuals, young people could remain on their parents' private insurance until the age of 26, even if they had a pre-existing condition or were no longer full-time students. So once we developed a way to pay for these services, the models that were developed across the border in Canada and Australia and in Europe became available in the States. A tragedy in the school at Sandy Hook Elementary School also propelled federal support in a surprising way. That is, the Congress's response to that school shooting tragedy led to a requirement that early intervention services be provided in every state, and resources for startup were added to every state's allocation from the federal government. And very quickly, the number of programs expanded from a mere handful 15 years ago to 350 programs across the United States now. So I think what's important here, and the reason that I went through this historical basis, is to show how the evolution over time and the change in the service model brought a field, mental health service delivery and mental health policy, into the social welfare policy arena, because it was recognized that individuals who have a psychotic illness in particular, but any young people who have a dislocation due to anxiety, depression that's severe enough to cause them to have functional limitations, have need for ongoing support. And that support can only come from the broad array of social welfare programs in the country. So we look across the border at Canada because, in our experience, your communitarian spirit and your sense of solidarity, you've done a better job, I would say, than we have done with the social network, providing a way to help people who have impairments and functional limitations. We're further ahead in the US for having begun to engage in these early intervention programs, but it's brought together the early intervention model that we gained from clinical services and public health and joined it with a much broader array of social policies and social welfare services. And the first step was recognizing the importance of mental health policy as a broad social welfare policy. So thank you very much.
Thank you so much, Howard. I would personally love to jump into some questions now, but I know we'll all be better served after.
I'm not running away. So.
Yeah, perfect. After we hear from Quem, I think there'll be even more. So I'll just introduce Quem, who's also a former colleague of mine. We've worked together, so it's a pleasure to do so. Professor Quem McKenzie is the CEO of the Wellesley Institute and a full professor at the University of Toronto. As a leader, policy advisor, administrator, clinician, educator, and academic with over 260 peer-reviewed papers, 6 books, he has worked across a broad spectrum to improve mental health, population health, and health services for 3 decades. He has advised health, housing, education, and social service ministers in Canada and the UK, and worked as a consultant to the WHO, and has completed terms as a Commissioner of Human Rights in Ontario and a member of the executive of the Royal College of Psychiatry in the UK. He has worked as a columnist for The Times and The Guardian and a presenter for the BBC. And for those of us in Toronto and Ontario, a regular guest on the agenda was Steve Paikin, and Quem and I got to do that show together a few months ago. So with that, I'll turn it over to Quem for your presentation.
Thanks very much, Tatham, and thanks very much for the introduction and inviting me to speak. And I'm really happy that you were able to cut it short, because those sorts of introductions make me feel tired. The older I get, the more tired I feel when I hear them. And it's really lovely to be alongside Tatham and Howard to speak about mental health and social policy. And I'm going to be taking this to in a different place and to a different place, rather than just thinking about treatment and treatment policies, or how treatment policies have linked to social policy. Because I'm going to really try and see if I can answer the question that was set for the blurb that we had about this session. So I'm honoured to be here, not just because this is such a historic institute, but also because the aim is improving social policy for a more resilient and successful future. And the fact that we've covered sort of in these sessions just about every important issue is really important. And the fact that we're now talking about mental health gives me the opportunity to talk about how mental health links into a much wider array of issues. And I'm really going to talk about three things. I'm going to talk about improving treatment of mental illness and substance use, and not about the techniques, but the need to actually think about the scale that we are thinking about when we're talking about access to treatment. I'm going to talk a little bit about improving prevention, because we often talk about treatment and we don't talk about prevention. And then I'm going to talk a little bit more about mental health, because we often talk about mental illness and substance use. So we're talking about diagnosable illnesses and problems that need intervention. And we talk about prevention of mental illness and substance use. But really, one of the things that is really germane to social policy at the moment is how you deal with mental health, mental wellness, and the psychological impacts of and reactions to social policy. So that's what I'm going to be talking about. And I start off with this treating mental illness. Now, one of the reasons people are very interested in treating mental illness and increasing the treatment of mental illness is because of these sorts of nasty statistics that we see all of the time. 500,000 people in Canada each week miss work because of a mental health problem. A third of people with mental health problems have unmet mental health needs. Mental health problems in Canada cost at least $50 billion a year, and much more than that likely. And Indigenous, Black and other racialized groups have higher risks of mental illness. Now we have a standard answer to what we should do about this. As Howard was talking about it, we've learned how to treat anxiety and depression. We've learned how to build models for early intervention and to treat psychosis. And so what we tend to say is, give us better access to evidence-based services, and we'll be able to make an impact on those statistics. And this can be facilitated by giving us more money. And the rationale for the more money is that in Canada, we spend about 7% of our health budget on mental health. But in other countries, say for instance in the UK, they spend 11% of their budget, and you get what you pay for in mental health. So if you don't spend the money, you don't get the access. It's also an attractive solution, this solution of expanding mental health care, because mental health interventions are pretty good. And many people who could benefit from effective social, psychological, and physical mental health or substance use interventions just don't get them. So if you can expand access to effective mental health interventions, you decrease the number of people and individuals who are suffering and families who are also suffering because of treatable mental illnesses and substance use problems. And on top of that, there are economists all over the world, and one of the most famous is Professor Layard at the London School of Economics, who've been able to demonstrate that access to effective mental health treatment and supports for people who are at work increases economic performance. So these are really important. Obviously, in most countries now, we have diverse populations, and so if we're going to increase access, we need to be thinking about equity. It turns out that actually most interventions, most policy interventions increase inequity unless they are specifically designed to decrease inequity. And so when we're thinking about this expansion, have to think about equitable expansion and access for diverse populations. So this is a moral imperative that people say, give us more money, expand services, because we have treatments that can decrease suffering and people aren't getting them. And I think this is important, but I also think we need to remember the limits of this approach. And some of that is shown from what happens in places like the UK. So the UK is spending 11% of healthcare money on mental health, but it hasn't actually solved the problems of long wait times, huge numbers of people not getting care, and social support problems that are needed. They have got coordinated, evidence-based, effective and efficient care, but they still have a mental health service that is overrun. So it may be moving from 7% to 11% of healthcare spend isn't going to be quite enough. The second limitation of focusing on treating mental health problems, of expanding treatment, is that many mental health problems actually develop into chronic illnesses. So if you suffer from depression, and one bout of depression, you're at high risk of suffering from another bout of depression. For psychotic disorders like schizophrenia, 2/3 of people will have multiple bouts of that illness. And so these are chronic problems. And so if you just treat them rather than try and prevent them, you can get into trouble. It may be that preventing them is more important than trying to just treat them. And the last issue, which is a limitation of the expansion of treatment, is that expanding treatment doesn't do anything about the differential risk and differential rates of mental health problems that there are for Indigenous, Black, and other racialized groups and other equity-seeking groups. And given the significant impact of mental health problems on people's economic prosperity, if you have certain parts of the population that have higher rates, you put those parts of the population at an economic disadvantage, and economic disadvantage is linked to life expectancy and other life chances. So just focusing on expanding treatment doesn't necessarily get us where we need to get to, and doesn't help necessarily everything we want to do when we're moving towards this sort of more resilient society. And so people have talked about preventing mental illness, and this is where we get very quickly into social policy. But just before I talk about how people have thought about preventing mental illness, you just need to remember that very few countries have deployed sustained and right-sized prevention strategies for mental health problems. Even though there's a fabulous literature showing that they are effective, it's been difficult to get and maintain traction and policy traction on prevention. And actually, at the moment, in Canada, we have our federal and provincial governments talking about mental health transfers, with the federal government wanting the provincial governments to be more evidence-based and to produce and to monitor and be able to demonstrate success and what they're doing with the money. But the conversation has almost exclusively been about treatment. It hasn't been about prevention, even though the most cost-effective, evidence-based way of decreasing mental health burden is by considering a balanced approach where prevention and treatment go hand in hand. And the reason for this is because people have done the math. So this is from the Canadian Medical Association, and this is their piece of work, which is called What Makes Us Sick. And what they tried to do was quantify what makes you sick, the percentage of the determinants of health that go into each bucket. And the long story short is 15% of what makes you sick is biological, and 85% is social. 85% has will have a social policy will have a traction on 85% of what makes you sick, whether it's your life, access to healthcare, or your social environment. And the social environment is something that has been there has been quite a lot of discussion about in the United States, and this is where they start talking about a pair of ACEs, adverse childhood experiences and adverse community environments. And each one of these adverse childhood experiences is exquisitely linked to rates of mental health problems, rates of substance use problems, and the ability to succeed in life, and similarly with adverse community environments. And so people are talking about whether policy initiatives to decrease the number of adverse childhood experiences, adverse community environment or adverse community environments could actually decrease the rates of mental health problems and the severity of mental health problems in populations. It's granted people do not believe that you can prevent all mental health problems, but you can significantly decrease the rates, the risk, and the severity. And there's quite a lot of evidence out there of evidence-based strategies targeting these different adverse childhood experiences and adverse community environments, which have been shown to make a difference. There's a growing literature. And indeed, when people do the studies, they demonstrate that for every $1 spent on mental illness prevention in children and youth, your return on investment is $5 to $7. So if we actually wanted to decrease and really have an impact on the statistics around mental illness, we would equitably increase access to services and supports for mental illness and substance use, and a wide array of evidence-based supports and treatments, but would also have a right-sized, focused social policy to try to decrease the rate of mental illness. So, but I think there's more we could and should do, and I'm not completely sure that focusing on mental illness alone will move us towards where we want to get of a more prosperous and resilient, sustainable society. So we're now in high-income countries, which are diverse societies. And we, as you know, are on this journey towards adaptation to produce more inclusive environments that allow as many as possible to thrive. Indeed, our economic advantage in high-income countries is linked to how we develop our thought and service industries rather than extraction industries, and we don't necessarily make as many things as we used to. And so it's about how we add value by building knowledge, innovation, and by understanding the current and future needs of our population. And in that thought economy, in that service economy, our raw materials are mental capital. And loosely, you can think of mental capital as IQ, EQ, and mental health. And IQ is intelligence, EQ is emotional intelligence, and mental health. And it's a concept which tries to capture and understand some of the psychological and psychosocial facets of an individual and also over a society or community that we need to leverage in order to produce effective and efficient running of a country. And the reason it can be considered as capital is you can invest in it, build it, deploy it, and leverage it to build society and economy. But also, as many other types of capital, the value of your capital can go down as well as going up. If you don't look after it properly, you can produce problems. So people have started saying, when you're building social policy, you may want to think about whether you're building mental capital. That means you have to consider the mental health impacts of policies when you are building them. Now, when I say mental health and I talk about mental well-being, I am talking not about diagnosable mental illness. I'm talking about the psychological ability to bounce back. I'm talking about psychological wellness. I'm talking about happiness. I'm talking about being able to be a productive part of society, which is not linked to just mental illness. Now, there are loads of strategies out there to think about how you think about thinking about mental health when you're producing mental capital. There are tools out there like the mental health impact assessment, which can be used as a decision support tool to consider the possible mental health impacts of social policy. And there are also social policies specifically that try to build mental health. And one of the most famous ones is this idea of 5 a day. And you know, like you have 5 a day, you're supposed to eat 5 bits of fruit and vegetables for heart health. And there's this idea of 5 a day for a mental resilience, which keep connected to people, be active, be aware, which is really about mindfulness, get involved, which is like learning new things, and giving back to society, so volunteering. And some people have started constructing social policy at a local level to try and allow people or facilitate the building of positive mental health and resilience through this sort of 5 a day. And certainly the UK National Health Service has taken this as being an important intervention. But a lot of people, you know, when we're talking about mental health impacts and we're talking about building positive mental health, some people say, well, it's still a bit vague. What do you mean? And so I just want to finish by talking about what's becoming a classic problem, a classic case study of what happens when you don't take mental health into account when you're building social policy. So I'm taking your minds back to 2020 at the start of the pandemic, and this is COVID-19. We were faced with an unknown virus which could cause havoc. Policymakers were rightly worried about the potential for the pandemic to be a disaster of historic proportions, and they decided they needed to do something. Now, many of us were concerned, and I was concerned right at the start of the pandemic, and I think in March 2020, I was writing that we really need to think about the impacts of whatever we do on mental health, individual and community resilience, and that there was an opportunity, if we thought it through, to be able to have a pandemic strategy which both helped us combat COVID-19, but also actually improved our social functioning. And I was talking about adding some of the evidence-based mental health interventions like the 5-a-day into the pandemic strategy. But at that time, policymakers weren't listening. They were focused on the virus. They were focused on getting the public to change their behaviors to decrease spread and transmission of the virus. And they were worried about the health system being overrun. And so what they did, they used the tried and tested methods of behavioral change, which is leveraging fear, self-interest, and emergency policies. And of course, we've got to say that this worked spectacularly. People stayed at home, they decreased their social networks, masked, washed their hands, sanitized everything, washed food when it got back from the groceries, and this probably saved 40,000 lives in Canada, somebody would say. The problem with it is that there are predictable costs. The two big issues are mental health and durability. There are many mental health impacts of the social policy measures that we had, but there are also durability issues. And let me just do this really quickly. When we talk about mental health, if we had done a mental health impact assessment, we would have very quickly said, you can use fear, self-interest, and laws, but if you make people fearful, more people get anxiety symptoms. If you tell them their whole world has changed, more people get symptoms of depression. If you send workers into dangerous situations, many of them will be traumatized. If you make people fearful, but you don't equip them to protect themselves, many will be traumatized and stressed. If you tell people to break their social ties, they may do, but that will have impacts on their short-term and long-term mental health. And if you shut down schools without properly equipping parents and societies to offer an alternative methods of socialization and the education socialization for their children, you actually lose a generation and you make a generation more vulnerable to mental health problems. Now, most of these won't lead to increased mental illness, but they will lead to less severe problems with well-being. And this was predictable and avoidable. The second very quick issue is durability. The problem with fear, if you don't do mental health impact assessments, is that we are not hardwired for long periods of fear. So what people do is develop anxiety problems, or they adapt by dismissing ongoing fears. So fear can help you do things in the short term, but it's really not good for maintaining any impact. It's really not durable. And the problem with self-interest is that it's socially corrosive. And so in the long term, it actually undermines your pandemic strategy. Pandemic strategies rely on social capital and other social programs and public support, and self-interest undermines that. So if you add together the problems of decreased mental health and the low durability of a pandemic response built on fear and self-interest, you get to exactly where we are now, which was always predictable. Social fracturing, care sector on its knees, increased youth mental health problems, and low confidence in government, all 100% predictable if we had done a mental health impact assessment at the start. Whether they were totally avoidable, we don't know, but mitigating strategies could have decreased them. And now we've got the last problem that comes with this model, which is we have the boy who cried wolf issue, where we may be in a very dangerous position. Actually, this year we've had the highest death rates from COVID than we've had previously, but we don't have the levers to move forward because of our social policy, because of the way we develop social policy. So the point I'm making is not that we need to think through whether we should have done this or that differently in the pandemic, but really to make the point that thinking about mental health and psychological impacts when building social capital may be one of the things we need to be thinking about if we want if we want to have the future of a more resilient and successful society. Thank you very much.
Thank you so much, Clem. And I didn't even know this coming in, but it feels like we've had a 200-year history of mental health treatment in the world and in Ontario, especially leading up to our very current situation. So thank you both for that. I had jotted down a couple of my own thinking and questions, and they were initially into different questions, but I can sort of wrap them up into one. Just basically wondering, I mean, both of you have talked about a shift, Howard, obviously from early days of institutionalization in hospitals to then moving out into the community, and then the recognition that mental illness and mental health was tied into social welfare. And then Quam, you've talked about issues of equity and the ability to know what was going to happen with the implementation of certain policies. And while Howard, your description of where things have moved, at least sort of philosophically, sounds very good, I think what Quam has been highlighting is that in practice, it isn't happening the way that we want to. So just wondering if either of you or both of you could comment on, what are strategies or ideas to make this very real, sort of the social determinants of health approach to mental health, or breaking down silos, or whatever sort of metaphor you want to use for it. How do we make that actually happen?
My short answer is avoid either or thinking. I didn't want to create the impression that the only thing that was important was treating severe and persistent mental illness, although that's what I've devoted most of my career to. The problem came when we did only one, or if we do only the other. And I think we need to embrace both. Both are really important to improve the overall mental health of the public.
Mm-hmm.
Yeah, I totally agree with Howard. I think either or thinking is one of the issues. I do think that we have, there's one of the issues that people talk about should have been in DSM-5, which is implementation deficit disorder. And I think we have that as in spades. We know what to do, we just don't do it.
Yeah.
But I also think that comes back to some of the issues of stigma around mental health problems, and the fact that to a certain extent we are allowing incredibly severe problems to arise because we do not give mental health and mental illness the prominence it deserves. And I think the stigma of that allows us to not be horrified by 500,000 people not being able to go to work for mainly treatable illnesses. It's incredible that we allow that to persist. And the question is why?
Right. Unfortunately, it feels like we've gone more from sort of a dialogue to presentations, but they were both so informative, and I think I certainly can take a lot away from it. And just apologies that I wasn't able to get to some of the other questions in the chat. But Carolyn, I'll turn it back over to you, and a big thank you both to Quam and Howard, and a real pleasure for me to hear you guys speak about your your.
It was good to meet you and good to be part of this.
Good to be. Thanks very much.
Thanks so much, Tatum, for turning it back. I truly wish we had more time for this very rich discussion, but let me just thank you, Tatum, and our speakers, Howard and Kwam, for what was a really wide-ranging and incisive discussion of the multiple ramifications of mental health and social policy. One of the themes that we've wanted to emphasize in this institute has been the interconnections across areas of social policy, and you've certainly forcefully driven that message home today from a mental health perspective. As I thought, this discussion has been a fitting capstone to the discussions of the major social policy areas that we've had to date. 2 days from now, as was mentioned at the end of the last session, we will conclude by turning to the public and political landscape on which the multiple dimensions of policy reform that have been discussed in this series will have to play out. The speakers in that session will be 2 leading experts on polling and public opinion, who will share some of their latest data with us. Carol Doherty, Director of Political Research at Pew Research Center, and Bruce Anderson, Chairman of Abacus Data. The moderator will be my good friend and colleague, Nathalie Desrosiers, Principal of Massey College. You can register online for that session on the Munk School of Global Affairs and Public Policy's website. Before closing, I would like to thank Employment and Social Development Canada and Immigration, Refugees and Citizenship Canada for their support, which has allowed us to bring leading international and Canadian experts to this public forum. And thank you all for joining us. Goodbye for now, and enjoy the rest of your day.